Hello, everybody, and welcome to St. John's Cancer Institute's Be Inspired Speaker Series, The Genetics of Cancer, Are You at Higher Risk? My name is Gene Goldsmith, and I'm a Development Director at St. John's Health Center Foundation. This is the first of two webinars on the genetics of cancer, with the second on March 1st, and we hope to see you on that webinar as well. St. John's Cancer Institute, formerly the John Wayne Cancer Institute, has been a part of St. John's Health Center for over 30 years. We are renowned for our groundbreaking research, pioneering surgical techniques, and bench-to-bedside translational medicine, focusing on major areas of cancer research, immunotherapy, molecular medicine, and the precision medicine that comes from analyzing each person's genetic markers that allows us to target treatments individually. St. John's Cancer Center is also home to the Donald L. Morton, MD, Complex General Surgical Oncology Fellowship Program, one of the oldest programs in the nation that trains the next generation of surgical oncologists. Our fellowship program has graduated over 150 fellows that lead programs and are deans of departments in major cancer centers all over the country. We also have international research fellows that train with our senior researchers from 1 to 4 years right here at in our labs at St. John's. Because of this academic level educational programming and world-class research, St. John's Health Center is in a unique position as a hybrid academic community-based hospital offering patient-centric care and academic level education and research. We also provide fantastic community education, and as such, we're looking forward to today's webinar. Before we get started today, I have a few housekeeping items that I would like to share with you. We would definitely love to hear your questions, so make sure that you ask those questions if you would. As you will notice, everybody but the presenters are muted so that we will all be able to hear them well. In order to ask questions, you will need to use the chat function at that's on your screen. So the chat function, it looks like a thought bubble, and it's located at the bottom of your screen. We will see your question and ask the physicians. If we do not get the answer to your questions, then we're going to follow up with an email to everybody with those answers for you. Please note, we cannot answer specific treatment questions, but we're happy to answer any questions about the subject of the webinar. We will be recording today's webinar, and it will be available on the St. John's Cancer Institute's website. And we will also send a copy to you after the webinar is over. So you will get an email with that copy, and you can share it with whoever you'd like. We have a very interesting hour in front of us as we hear from a clinical geneticist, a medical oncologist, and a surgical oncologist who specialize in the use of genetics in their medical practice and research. I'm very honored to present them today. Our first panelist is Dr. Ora Gordon, and she's a nationally recognized expert in hereditary cancer, and she's also the medical director of the Regional Center for Clinical Genetics and Genomics for Providence, Southern California. She is the clinical director of the recently established Providence St. Joseph's Health Population Genomics Program and the principal investigator for the system-wide Genome for Me study. Dr. Gordon is board certified in internal medicine and medical genetics. Her primary research interests include identification of hereditary cancer in the general population and individualizing risk for common disease. Passionate about the holistic approach to medicine, she's also completed a fellowship in integrative medicine to expand options for primary prevention and nutritional research for high-risk patients. Dr. Gordon has co-authored an award-winning book for women facing genetic risk for breast and ovarian cancer called Positive Results, Making the Best Decisions When at High Risk for Breast and Ovarian Cancer. Our second panelist is Dr. Parvin Peddi. Dr. Peddi is a medical oncologist specializing in breast cancer and is the director of the breast medical oncology at the Margie Peterson Breast Center at St. John's. Dr. Peddi is involved in designing, implementing, and leading clinical trials to test new targeted therapies. She's board certified in internal medicine and medical oncology and came to us from the UCLA Medical Center, where she was the lead medical oncologist at the Revlon UCLA Breast Cancer Clinic. Dr. Peddi was selected as a Howard Hughes Medical Institute scholar to perform research at the National Institute of Health in Bethesda, Maryland. Her research has been published in various medical journals, including the New England Journal of Medicine. And our third panelist today, and who is also going to be moderating, is Dr. Anton Bilchik. Dr. Bilchik is a surgical oncologist with a PhD in gastrointestinal physiology. He's an internationally recognized surgeon and scientist who has pioneered techniques to improve staging cancer and minimally invasive approaches to improve outcomes. Dr. Bilchik is trained and certified in advanced laparoscopic and robotic surgery. He's an investigator on international multi-center clinical trials, has written over 220 publications, and is considered one of the country's leading specialists in surgical oncology. Dr. Bilchik will also be co-leading the Digestive Health Institute at St. John's when it comes on board in the next few months. So this is our group today. We're so excited to hear what everyone's got to say. And thank you so much for moderating today, Dr. Bilchik. Take it away.
Thanks very much, Jean, and to my fellow panelists. This is really going to be an exciting hour. In the 25 years that I've been at St. John's as a fellow, as a faculty member and a researcher, I don't think genetics has ever been as relevant and as important as it is right now. We are always asked the question when we see patients in our clinic that are diagnosed with cancer is, why did I get it? What's the cause? Did I get it from a family member? Is it genetic, or is it related to something else? And so the discussion really begins the moment we see our patients. And I'm going to start off by asking Dr. Gordon, which patients are considered at risk? If someone comes to you and says, do I have is my cancer related to a member of my family? Where do you even begin the discussion?
Thanks, Anton. That's such an important question and something that really all of us deal with every single day. And there's no single answer that is, kind of encompassing for all. I will say that, family history is exceptionally important in trying to understand those who are probably at the highest risk for having a hereditary or predisposing cancer. But we use these big benchmarks. How old were you when you got your cancer? Have you had more than one type of cancer? Have you had cancer on both sides? If it's something like breast cancer or kidney cancer that is on both sides, have you had more than the 2 times you've had a colon cancer? So these are big flags, but there are certain cancers to which there's so much hereditary risk that we say we need to test everyone who has had this type of cancer. Examples of that are ovarian cancer, pancreatic cancer, and some specific types of thyroid cancer. I'll turn this over and have Dr. Peddi also weigh in. What we are learning, though, is that the more we look, the more we find. And this is really changing the model from saying you have to have a neon sign, you have to have breast cancer under the age of 40, you have to have had colon cancer very early, you have to have enormous numbers of colon polyps to come to the attention of being a hereditary type of cancer in yourself or your family, to saying, you know what, 10% or more of all what we call solid cancers probably have a single gene we can identify as a risk, and even up to 30% have a genetic vulnerability, which we're starting to be able to understand.
Thank you. And, the discussion for genetics clearly started a long time ago, but became even more important with the discovery of the BRCA gene. The BRCA gene certainly is the gene that most people are familiar with. So I'm going to ask Dr. Peddi, which patients that are diagnosed with breast cancer should be tested for the BRCA gene? As Dr. Gordon mentioned, should it be every patient, or how do you decide which patient to be tested?
Sure. So those are great questions. And just like Dr. Gordon was mentioning, our criteria is expanding as we go along because we're realizing more and more patients either have a gene that we can do something about, or that it would actually impact their treatment in one way or the other. So right now, anyone who is less than age 45 should get tested if they have breast cancer and they're that young, but a lot of other criteria as well, and it takes a whole page to list them all. But let's say triple negative breast cancer, if you have that, you should get tested. You have a high risk estrogen positive breast cancer, you get tested too, because now we actually have medications that specifically attack the BRCA mutation. So bottom line is you should talk to a genetic counselor, you should talk to your doctor, go over all the criteria, and we're testing more and more patients because we're realizing they will actually change their management. So that's for breast cancer. And then what Dr. Gordon was mentioning for ovarian cancer and several other ones like pancreatic, test everybody, but it's not really being done actually. So like it was just an article that came out like about a week ago, I think. It was in one of our leading journals, JAMA, and they looked at what percentage of women with ovarian cancer end up getting tested genetically. And as I mentioned, and Dr. Gordon said, everybody should. And it was only about a third actually ended up getting genetically tested. And this affects their treatment, affects their, if they have localized disease, how you monitor them, and obviously for their family members. So yes, so definitely this is something that needs to be even more at the forefront than it is now, but we're getting there.
So, so with that in mind, you recommended to your patient to get tested for BRCA, and this is really a question for Dr. Gordon now, but your patient says, why do I need to be tested for BRCA? I had the 23andMe test and doesn't show anything there regarding BRCA. 23andMe is so widely advertised. It's on every news channel, it's in every magazine. What are your thoughts about 23andMe, Dr. Gordon? Is it good enough testing?
That's really important, and I think for the audience to really understand the difference between direct-to-consumer testing and clinical grade testing, and what is now becoming more accessible in terms of patient-driven testing. If I can just take a moment just to roll back a little bit related to what Dr. Peddi was saying and some of the things that we're doing at St. John's that are unique in terms of helping to get the right patients tested and making access so much more readily available. So one is part of a population initiative that we're doing for ovarian cancer patients throughout our health system, but focal to us in Southern California is for all patients with ovarian cancer who have been diagnosed within the Providence system to offer all of them germline testing, meaning testing to see if they have a hereditary like a BRCA susceptibility to their ovarian cancer, as well as looking at their tumor to see, is there a target for their therapy? And we're doing this on a universal to say, we recognize that even when the guidelines say everyone should be tested, not everyone is being tested. We have a similar, that's throughout the whole health system. Through us locally at St. John's, we have a walk-in clinic. That doesn't mean that anybody can just walk in off the street, but if you get your care for cancer in our cancer center, anyone can come in during the regular operational hours and get some video to help educate them about genetic testing and then get tested on that day. So we're really trying to break down the barriers of another appointment and scheduling out in the future and coordinating schedules and those sorts of things, and then have all of that be individually unpacked for that patient to say, okay, you were positive, this is what we need to do, you were negative, but we still think that this is high risk and this is what you and your family needs to do. So I just wanted to bring that forward as something that we're really doing to help to change the footprint of who can get genetic testing and how easy it is. Now, for your 23andMe question, really, when we are thinking about sort of the healthy population and people who are very engaged and really engaged in their own health and super interested in genetics and genomics and how does this, what are the things that can impact them? Companies like 23andMe have really, broken ground to say, we're going to get genetic and genomic information into the hands of the person to let them be the citizen scientist. And I think that that's an amazing opportunity for interest and engagement and understanding, what that tells you. But 23andMe is not a medical grade test. And very, very importantly, 23andMe related to the BRCA, or what people call BRCA, only tests for 3 specific changes amongst the thousands of mutations that occur in BRCA1 and BRCA2 that is unique to the Eastern European Ashkenazi Jewish population. And the reason why they test for those 3 is because the platform that they use, that's how they happen to be able to find those 3 genetic changes. So if you're not Jewish, it's totally irrelevant. If you have a significant personal or family history, it is completely inadequate. Not only does it barely touch all of the mutations in BRCA, but there are more than a dozen genes predisposing to breast cancer or breast and other cancers, of which none of those are assessed via something like 23andMe or any direct-to-consumer testing.
Thank you. So Dr. Gordon, I mean, what's very apparent is that, and you've been very instrumental in sharing with us the importance of genetics with just about every cancer. And, for patients to have to go to different doctors to discuss their diagnosis and then to make an appointment with another doctor for genetic counseling and then another doctor to discuss medical oncology. I mean, to bring it all home, which you've been, very instrumental in creating at St. John's, really creates a somewhat, unique environment to really enable the patient to get a lot of information in a short period of time. So that leads me to my next question, Dr. Peddi. Just walk me through the process of a patient that you see in the breast center that you think should get genetic screening. Just walk me through a day in your clinic.
Sure. So we have a unique model. We have this so-called multidisciplinary clinic, and we do it twice a week. And for newly diagnosed breast cancer patients, they get to meet with everyone on the same day. So everyone includes medical oncology, surgery, radiation oncology, and genetics. So when we discuss the patients, we always say, okay, this is a patient that should also see genetics, and this is the person that maybe not. But then we have the discussion that same day, and they get their labs drawn that same day for genetics, if they are appropriate genetic testing patient, and then they get the results, a week, a couple of weeks afterwards. So that is done seamlessly at the same time. Now, for patients who are not newly diagnosed, or they are, but they don't need surgery and they don't go through that clinic, then if I see them in my own clinic, for example, everybody who has metastatic breast cancer should get genetic testing. And those patients, then I would be reaching out to the walk-in clinic and basically sending them that same day. They see me, they walk right over, or they maybe even stay in the same exact room. And we start playing the video for them that actually goes over the genetic, testing and what it means and what we're actually doing, and then get the labs drawn and meet with the genetic counselor as well. So it's very seamless, and we're all in exactly the same place, same exact floor. So there's not a whole lot of see this doctor and then a few days later go see another doctor and get shuffled between all the different physicians, which is a big deal. You're already dealing with a lot of doctors, and at least seeing them at the same time really makes a difference.
Thank you, Dr. Peddi. I'm going to shift gears a little bit to something that's, near and dear to my heart, and that's colon cancer. We've seen an explosion among young people under age 50 being diagnosed with colon cancer. It seems to be going up among young people quicker than just about any other cancer for no clear reason. Just about every week, we're seeing someone diagnosed with under age 50, so much so that the guidelines for screening change from age 50 to age 45. So my question for Dr. Gordon, for the 42-year-old patient who shows up with newly diagnosed colon cancer, who's not obese, who's not diabetic, who's not a smoker, who says, how did I get this? Where do I go from here? What are your thoughts regarding genetics, nutrition, risk factors, etc.?
So yes, it's very upsetting to all of us who take care of patients with cancer to see this trend, this national and really sort of global first world trend of diminishing ages of onset for colon cancer. When we talked about early, when we started sort of these, that we've always used sort of a threshold of age as being a big indicator for whether there's a hereditary cancer. There are some pretty common hereditary susceptibilities to colon cancer and colon and women's cancers, so ovarian and uterus cancer. It's a syndrome called Lynch syndrome. We in our hospital screen every single colon cancer, every biopsy that's positive for cancer, and every resection for indicators in the pathology lab to say this could be a Lynch syndrome related cancer. There are specific markers in the tumor that says this suggests that this is this hereditary form of cancer. 1 in 30 patients, independent of age, have this susceptibility. They may not have ever had any idea that they were at risk for colon cancer or any other of these connected cancers. So this is a very important thing to sort of pre-screen everybody. It turns out that that also is very important to therapeutic decisions, and we may be able to talk about that particular vulnerability, making it unusually responsive to a specific therapy called immunotherapy. But if that is normal, meaning that that screening test does not show that this looks like it's Lynch syndrome, just based on that age alone, that patient should have comprehensive genetic testing. Because again, like the parallel with breast cancer, there are a dozen genes that predispose to colon cancer. If comprehensive testing is negative, then we start to look at the things that came up in the chat. What else is going on in terms of that environment? You speak to some of the known risk factors in terms of an inflammatory state that increases the risk for colon cancer. There's a lot of work being done looking at the microbiome and what has happened in terms of our modern nutrition, and even from our in our neonatal period, and are we getting breastfed and what kind of nutrition? And that's something called epigenetics, or the silencing or the errors in cancer genes that occur local to that area, to those cells. And that seems to be what may be explaining some of that earlier onset in cancer. For those who have a family member with early onset colon cancer, like you said, Dr. Bilchik, we are now recommending earlier screening. The guidelines are shift not only for all comers, but if you have a positive family history and a positive family history of early onset colon cancer, and we don't find a genetic change, we may still recommend earlier and more frequent colonoscopy. Aspirin therapy is something that I use very frequently from a primary prevention to protect people from colon cancer. It's not right for every single person to be on aspirin because there's bleeding risk. And so we balance, are you at elevated risk? And should we give you aspirin, and should we give you low dose aspirin or regular aspirin in addition to other nutritional things to try to help protect people from cancer?
So, Dr. Gordon, you touched on the therapy of cancer and how genetic testing can influence therapy. So I'm going to ask you a question first, and then have Dr. Peddi follow up. There's clearly been an abundance of new treatments over the last decade, particularly relating to immunotherapy. In the past, the treatment for most cancers has been either surgery, radiation, or chemotherapy. And immunotherapy, which just to give Dr. Morton some credit for, 40 years ago, was a strong believer in immunotherapy as a treatment for melanoma. And at that time, there were very, very few people that actually supported his notion that immunotherapy is likely to be the most effective treatment for melanoma. Now we have many, many immunotherapy drugs available, but we also have more sophisticated, genetic testing. So the question really is, and you touched on this, how does genetic testing influence what treatment you may or may not benefit from? And then we'll hear from Dr. Peddi.
Want me to answer that first, Anton, maybe, or do you
Yes.
want?
Yeah. So yeah, Dr. Gordon, let's start with you, and then we'll hear about breast cancer from Dr. Peddi.
So interesting things that we've learned. So in general, right, we've always thought of the hereditary cancers as being rare, that these were the zebras amongst the stallions of cancer overall. And there was a sea change in recognizing that, in fact, the underlying genetic vulnerability is far more common than we ever thought before. And there, in the flip, when we start looking at healthy populations, so a lot of work that I've been involved in is looking at, can we identify risk in somebody before they even present with any cancer, or if they don't have a screaming family history that says, oh my gosh, you really need to go get genetic testing, and have that kind of come to the attention of their providers. So I want to be able to speak to that a little bit later, because I think it's a very big audience to try to identify that. But these unique genetically driven cancers have become the precision medicine, the beneficiary of precision medicine, because we understand the biology of those tumors and have allowed for the targeting of therapies specific to the cancer that tends to be much easier to tolerate and much more effective and much less toxicity, because it's really exploiting the genetic error in the tumor itself. And that you could be predisposed, and then when you have the series of errors that happen, whether that be another genetic environmental change, whether that be radiation, whether that be years on the planet, the other things that are required to take a predisposed cell and turn it into a cancer cell, we can then hit that with immunotherapeutics, for example, for certain categories. There's a whole category of genetically driven hereditary cancers that are exquisitely sensitive to immunotherapy, or that there are, like Dr. Peddi was talking about, unique targets. So BRCA, for example, has a category of therapeutic medication that is oral, that is uniquely vulnerable to cells that have errors in BRCA and in DNA repair. And so now we say, okay, well, it worked in the hereditary ones. Let's see if we can get it to work in patients whose cells and their cancers kind of are acting like that, and be able to offer it to more and more patients. And so it's been able to inform, sort of the less common to be able to reach the broader audience, but it's the most effective in the hereditary cancers.
So Dr. Peddi, do you want to just expand on that and how you manage patients with breast cancer that are genetic mutations?
Yeah, absolutely. And I can touch base on breast cancer as well as ovarian cancer, because they're kind of similar in that aspect. So the class of medications that Dr. Gordon was talking about are so-called PARP inhibitors, and are oral medications, they're pills, far less toxic than chemotherapy, and much better, easily tolerated. So now we know that in patients with breast cancer who have the BRCA mutation, and whether they're metastatic or they had a large amount of cancer, but they got it out surgically, they would benefit from these class of drugs called PARP inhibitors. And in people who are metastatic, these PARP inhibitors actually do better than chemo. So less toxic and more efficacious compared to chemotherapy. And in patients who don't have metastatic disease, for now, still chemo is in addition to that. They would get chemo, but then they would get started on this PARP inhibitors, and improves survival and reduces the chance of the cancer coming back, specifically in this patient population. So you have to know that the patient has BRCA mutation to be able to offer this medication to them. Otherwise, they would lose out of this potential benefit. And the same thing with ovarian cancers. We know that patients who have the BRCA mutation and have ovarian cancer, now we're putting on so-called maintenance PARP inhibitors. So we give them chemo, we put them, and hopefully in remission, and then a couple of years of PARP inhibitors to kind of hopefully put it to rest and for the ovarian cancer not to come back, or for patients who have metastatic disease, at least keep it at bay for far longer than they would have been otherwise, and with much less side effects. Because again, it's just an oral pill. It doesn't cause hair loss. It doesn't do the side effects of chemotherapy at all. So that's the class of PARP inhibitors. And then in terms of chemo drugs, we also know that specific chemo drugs work better in patients who have the genetic mutation, mostly BRCA, but maybe some other ones as well. And those are the platinum drugs, drugs called carboplatin or cisplatin. We know that both breast cancer and ovarian cancer patients respond exclusively well if they have this BRCA mutation to these chemotherapy drugs. And so not only do you know what chemo drugs are better, you also know that these patients are actually going to do better than other types of breast or ovarian cancer. Their prognosis is even better. So you open up some treatment options, you go after some chemo drugs that are more effective, more so in these patients, and then you also can get a better picture to the patient that you're going to do much better because actually we know you have this and your cancer is going to respond very nicely.
And this truly highlights the importance of multidisciplinary care. I can just imagine someone having a positive mutation and just being in total despair, thinking that the treatment options may be limited. But what you're really saying is that there are many, many treatments, and really in some situations, the treatment may even be more effective. Exactly. If you carry the mutation. So what happens in a and I'm just going to give you a different scenario, and I'm sure you encounter this a lot in your practice. So you have a 45-year-old woman who's diagnosed with breast cancer, and you ask her family history. Her sister was diagnosed at age 48. Her mom was diagnosed at age 60. They've all been tested for the BRCA gene, but the BRCA gene is negative. Does that mean that there definitely is a gene there somewhere? We just don't know which one it is, or that it's just bad luck?
I'll let you take it away, Dr. Gordon, because yes, there's a clear answer on this one.
So it's incredibly important for patients who have personal and family history and who've had genetic testing in the past to sort of have a touchstone to say, is there what's evolved? Even in just since the 20 plus years that we now have had BRCA testing or BRCA testing, that test itself has improved 3 times over the course of just those 2 genes. And remember, we have 20,000 plus genes. We have known about 100 clinically relevant hereditary cancer susceptibility genes, and that knowledge keeps changing and evolving. So one, if you had BRCA testing or BRCA testing in the past, it very well may be that you need update testing just to have the most comprehensive and most exhaustive BRCA testing. And in addition, now we moved over the last 5 years from saying we're going to just test for one gene at a time to really moving to multiple genes. And the crossroads of what has happened from the genetic testing space, the germline testing space, is that the molecular technology has become extraordinarily efficient at finding genetic changes, and the cost of that and the rapidity, the ability to do that quickly, has absolutely plummeted. So whereas 8 years ago, just testing for BRCA1 and 2, the BRCA genes, was $4,000, and those were the only 2 genes you got. Now, for $250 to a patient at most that they would have to pay, we can test for 100 cancer susceptibility genes. So the knowledge, the power of that information is just exploded in terms of being able to identify risk. If you have had the most comprehensive 2022 level of genetic testing, and we still haven't found anything, and you have that burden of family history for breast cancer or colon cancer, then we do something that's called empiric risk assessment. So if you personally were unaffected, or if you have had cancer, but you have this very strong family history, and we're trying to say, hey, are you at risk for a second cancer of the breast or other cancers? How do we need to manage you? So then it becomes very personalized. There is actually a whole new category, very novel category of genomic testing, where we look at little tiny nuances in unaffected people primarily, for breast cancer, for prostate cancer, for colon cancer, and say, you seem to be loaded. You're a little stacked towards breast cancer risk or colon cancer risk. We need to watch you differently. We need to add in a breast MRI. We need to have you have colonoscopy more frequently. We may be considering preventive medications for you. Those sorts of things to really be, individualized in our cancer. And the flip side of that is saying everything is negative and your polygenic risk is really low. Even though you have this family history, we're super reassured. And you don't need to be so fearful that you're under this anvil of worry, and that we can perhaps roll back care that you've been getting, mammograms and MRIs every year. And maybe you don't need all of those all the time. And that is also the power of reassurance. And that's where we're going from this sort of precision assessment of risk and how much has changed. It doesn't change every 6 minutes, but it can be nothing for a year or 2 years, and then suddenly this big leap to kind of the next generation of things that we can offer. So for any patient who has had an evaluation in the past or who's considering those things, really have to sort of keep coming back around and saying, hey, is there something new? We like to touch everybody once a year and say, is there something new or not? If there's nothing new, you're staying the course. If we have something, then we reoffer.
And Dr. Gordon, does this require a blood test or a sample of a tumor or a sample of tissue? Also, if you can just expand on what you're talking about, because you're now running this hugely exciting trial called the Gallery trial. And can you just tell us a little bit about how that ties into what you're talking about relating to early detection?
So one of the other things that have really made genetic testing germline, or what we call germline, so the hereditary genetic testing, very easy, is that it is equally valid in saliva as it is in blood. And so this has allowed people the freedom of being able to get genetic testing through a spit kit, and they don't have to have a blood draw. And so if blood draws are challenging, or just sort of scheduling that. The current testing that we do to get the very best testing looks at not only the DNA, but something else called the RNA, so the messaging, and people have probably learned a lot about RNA these days with the COVID vaccine, so sort of the programming coding for the DNA. And we look at both of those together. That still requires a blood test. So depending on your level of risk and your access, you can do genetic testing on saliva, and it is totally valid, but that the RNA testing is a little bit better. And so we prefer to do blood testing for our germline testing. In two initiatives that are looking at, and there may be patients who have been invited to participate. One is called the Genome for Me. So it's Genomic Medicine for Everyone study. And that is really looking at the population, saying if you develop cancer and it's a hereditary cancer, we've missed our opportunity. That we want to find people at risk before they present with cancer, so that we can intervene in meaningful ways to prevent them from ever getting cancer or finding it at the very, very earliest stage. So that initiative, and there are patients who are primary care patients who are part of the St. John's and the broader Santa Monica community, we are outreaching. There's something I also want you to talk to about, Anton, that our health systems commitment to the underserved and underscreened population and how important that is. The Genome for Me study is also recruiting patients who are coming from ethnically diverse populations and historically underserved, both in genetics and in healthcare. So that's trying to find people before they know they have a hereditary risk. I see that there are a lot of questions in the chat too about kind of assessing for family history and what to do specifically if you have a genetic change. We have guidelines So there are insurance guidelines that say, if you have this family history, you're eligible for genetic testing. If you have this personal history based on age or the specifics of a tumor, you're eligible for genetic testing. If you've had more than a certain number of polyps, all of these things are sort of pretty strongly kind of guardrails, but we have the ability to offer genetic testing, like I said, in a proactive way, even outside of study, for $250 or less for patients who are just worried that they may have a genetic susceptibility. That's how available and accessible genetic testing is now. The other big study that we have just launched, and thank you for bringing that up, is this blood test that's a multi-cancer early detection test. And the company is called Grail, like the Holy Grail to find cancer, and the test is called Gallery. And we are offering to all of our high-risk patients who have a hereditary susceptibility. They carry BRCA, they carry a CHEK2, they carry a gene for leaf-Romani. I see that all of those are within the chat. All of those patients who are patients of ours are eligible for this blood test, which tests for up to 50 types of cancer at one time. And we're really looking at trying to say, who is this best for? What's the interval, that timing? Should we do this once a year? How does this tie into other screening that we're asking people to do, like getting invasive endoscopies or getting MRIs of their whole body? Can there be the best integration of all of this information? And then for patients who are cancer survivors, we have another arm saying, okay, you had cancer, you're free from your cancer. We always talk about you being at a little bit higher risk. Is that a population that this blood test, this liquid biopsy test would be good to say, you know, we can find cancer the earliest before there's even any screening, or if you've gone back to routine surveillance, you know, do we need to be doing something different for you?
So in the interest of time, we're going to, open up questions from the audience. I think I saw one just flash up about who is eligible.
For the studies?
Yeah.
So for the Genome for Me study, so the Genome for Me study is open to any patient who is part of Providence. We have been directing it to certain clinics, as well as this outreach to our community outreach to underrepresented. If you're interested in that study and learning more, you can just you can put something into the chat and we'll follow up with you about that part of it. That is clinical grade whole genome sequencing that is being done by our molecular lab in Portland, with return of results for cardiovascular risk, for hereditary cancer risk, and something called pharmacogenomics, which is, do you react to medications differently than others? And for patients who have personal histories or family histories that are significant, of course, speak to your doctor about getting a referral, or reach out and call us at our genetics department, and we can help facilitate coming in for an appointment, or how other pieces of information you can get. The Gallery study is specific to patients who are identified as patients of ours who are high risk for hereditary cancer, or are high risk because they are cancer survivors. And then we're doing a primary care arm up in the Pacific Northwest, reaching out to just patients who are over 50 or who have tobacco or other exposures.
So Dr. Peddi, in a perfect world, because there's so much work being done right now from Providence and at the Cancer Institute in terms of cancer prevention, early detection, if you had the resources to improve the current genetic screening program in the breast center, what do you think we're missing?
I think in the perfect world, like almost everybody who has cancer would get genetic testing, perhaps. That would be in the perfect world. But the majority of them right now probably won't have a genetic predisposition, at least with the gene testing we have. So what I would like in the absolute perfect world is what Dr. Gordon is describing, I hope will eventually happen, that in a simple blood test, I can tell patients, you're at risk for this cancer or that cancer or this cancer, and I can give them specific risks for each one, and then that I have drugs for each one of them to be able to treat the patient. Right now, I only have drugs mostly for the BRCA mutation patients in terms of breast and ovarian. Not so much for several of the other ones, let's say CHEK2 or CDH1 or things like that. I don't really have specific drugs for those patients. So research really needs to be developed to get targeted treatments for all the different genetic mutations that can cause all these cancers. So once you find them, there's something specific you can do in terms of treatment. There are things you can do already in terms of how you follow them, at least how actively you do mammograms, you do MRIs. So there are things you would still change as a result of it, but I'm hoping some point in the near future we'll get to medications as well. So that would be in the perfect world.
And Dr. Gordon, there are a bunch of questions which are exactly in line with, your expertise, and that is, the role of nutrition, supplements, vitamins. Where do they fit in? Do they have anything to do with any of these genetic mutations? What if someone tests positive? Should they change their diets?
So there's a ton to unpack in that question. I want to just address a question related just back to Gallery, because I may not have been totally. Anybody can get the Gallery test is available commercially. So it is available to anybody who wants it. We are looking at it in the study environment for patients who are unique populations, so our high-risk patients, and then really looking to see who is it best serving in a primary care setting. How do we bake that into sort of usual guideline recommendations of when you get your mammogram and when you get your colonoscopy, and does that help people adhere to the routine recommendations that we're having them. For patients who want, for anybody who's in the audience or patients who are of Providence, who have Providence providers and want the Gallery test, there is a commercial access to that. We still want everybody to be part of a national registry that we're involved in, looking at this as an outcome for 40,000 patients over 5 years to say, what is this test best, in what populations does this work best in all comers? Providence patients have can get that test at a discounted rate of about $818 or so, compared to almost $1,000 if you just go to the Grail Gallery website. So we'll give that link and connection to providers who are offering it on the commercial side. Patients who are in study are not paying for the test. It's being a part of this high-risk initiative.
Yeah, if I could jump in, sorry, Dr.
Yeah.
One thing. So, and then patients who have cancer, just for the audience. So we are enrolling patients on the trial as well. People who have been more than 5 years out, early detection in terms of whether the cancer has come back or not. And that's sort of like a side project of this whole genomic thing. And then that's also free of charge. So if you're able to satisfy one of the criteria for the trial, you're able to get it free of charge. But if not, like Dr. Gordon mentioned, there is a price, but you can get it.
So one of the questions, which I think is a very good one from our audience, is where does it begin and where does it end? Sisters, uncles, aunts, grandparents, first cousins, second cousins.
So I tell everybody that Thanksgiving should be Family History Day. You come with a whiteboard, and you should just, because there's institutional memory, right? So like Nana, Zadie and whatever, they have information which may or may not be totally accurate, but be able to give us information to the legacy of their family that once they're gone, that may be gone. If you get really interested in sort of genealogy, there's an enormous amount of information you can actually get on relatives, death certificates, and other things that can often be super informative about helping to bake your family history and family tree. One of the great travesties is when patients are told that their family history, for example, of breast cancer doesn't matter because it came from their father's side, and that there's continues to be this misunderstanding that cancers that perhaps are gender specific, like prostate cancer or breast cancer that tend to be, much, much more in women, can't be passed down from the alternate genders line. And this is totally incorrect. So you can have your father have an ovarian cancer gene. He's not going to get ovarian cancer, but he can pass that down to you at a 50% risk. We tend to look at the first degree relatives, parents, siblings, and children as being the biggest drivers of risk to any one person. But but we take into account all the way to the grandparental. And when you come into genetics, we take a 4-generation pedigree, and that's that all of that matters. One colon cancer in a great uncle is not going to impact your personal risk for colon cancer in any model or any kind of statistical risk for having a hereditary susceptibility. That gets you into sort of the 2% carry some crappy gene that we can now find if we test for it. The nutrition and dietary is really well beyond the things that we can talk about here. The short answers are that the ideal diet for everyone, every single one of us sitting here today, and everyone that you know and love, is an anti-inflammatory based diet. There's so much information related to inflammation as the driver for cancers, for all cancers. And so you don't have to be like crazy about what goes into your mouth, but you should definitely avoid category 1 carcinogens, which alas are the delicious things that you get in an Italian deli. So nobody, frankly, should be eating on a regular basis mortadella, highly processed meats. If you like beef, you should eat grass-fed beef. There's data there that is very helpful. The more you can have your plate look like something that you would get at Benihana's, which is 3/4 plant-based and then 1/4 protein and animal protein, fish-based foods. These are all kind of things that people say, yeah, we know, but there's really good data to that. On a global level, I'm a huge fan of turmeric as a supplement, and I spoke to the use of aspirin judiciously is very important for the protection and prevention of a number of cancers, particularly colon cancer, in the appropriate patient. Keeping your vitamin D, assessing and keeping your vitamin D level at a normal to the higher end of normal is very important globally from both in an anti-inflammatory, and there's some data related to cancer-related risk. Exercise is the unsung hero. We are in Southern California and people are super active, but the data on exercise in the prevention of recurrence, particularly in hormonally driven cancers like breast cancer, is as powerful as the medication that we give. So you don't have to be a marathon runner, and people who don't exercise often feel very daunted by that, but you can move. If you can move 30 minutes, if you can get 150 minutes of exercise a week, that is actually the prescription for risk reduction. So there are things that are really within all of our power to teach for ourselves, to teach for our children, that we can do to help in terms of that risk.
But Dr. Gordon, where I'm a little confused is that all these pro-inflammatory type foods such as alcohol, all that, the foods that make you happy, if you stop all that, then your stress level goes up. And doesn't stress cause cancer?
Well, and I can certainly let Dr. Peddi speak to alcohol. I mean, it's a very direct corollary. You can have a safe amount of alcohol. You can have a glass of wine, and not the big mama glass where the whole bottle goes into the glass. That doesn't count as a glass. It actually has to be 5 ounces. And that is a J curve. That is protective. It's cardiovascularly protective. It's well-being protective. It's really good for you if you enjoy it. And then it becomes linear. If you have more than 2 drinks a day, 3 drinks a day, there's a direct risk associated with breast, hormonal cancers, colon cancer. So, but yes, from a stress reduction, nobody wants you to live longer and be unhappy. That is not the goal. The goal is to find ways to, and we have mind body. We have programs at St. John's related to mind body wellness, to stress reduction, all of these things in terms of that integration for things that will help work. And if you can transmute, the 3 drinks into 20 minutes on the treadmill, then, I think everybody wins.
Yeah, completely. And yeah, because alcohol increases estrogen production. It's as simple as that. So in a woman, alcohol just does that. And the more estrogen a woman has on board, the more busy her breasts are, and the more likely a possibility of breast cancer happening. So general recommendation is less than 3 drinks a week for the most part. But again, that's just average. It's just a matter of a little bit, not every single night. Some people say, oh, I have a glass with dinner. Every single night, that's a little bit actually too much in terms of breast cancer risk in a woman. So in terms of alcohol, that's what I would recommend. And don't be stressed about the stress. That's generally what I tell my patients, because it's not that because you're stressed, you're going to get cancer per se. There are people who are completely zen and completely okay and get cancer, and they're vice versa, people completely stressed and never have anything. But try obviously to have less stress just in general, but don't be so concerned that, my God, my stress went up, now I'm going to get cancer tomorrow. It's not like that kind of correlation.
So the moral of the story, Dr. Peddi, is that it's okay to drink a glass of wine, but it needs to be a good glass of wine.
There you go. There you
One
go.
really good glass of wine.
Okay. So I'm going to turn it over to Jean, but, great discussion. Thank you, Dr. Gordon, Dr. Peddi, and over to Jean.
Thank you very much, Dr. Bilchik. And, it's an incredible discussion, and looking at the questions that have come in for this hour, I know that we will be following up in an email to answer some of these questions that we couldn't get to today. We're going to follow up with a number of things. So if you would like information about the Galleria test, Genome for Me, we will make sure to have information on, in that email to you as well. This discussion is incredible. If we had this conversation 20 years ago, it's a completely different conversation. So it's just incredible to see how much has improved and changed. I mean, the ease of getting testing, the has gone up, the cost of testing has gone down, the specificity of testing has gone up. We use this for screening and prevention. We use this for treatment. It's not just if you've got a variant, but if you've got, I thought it was very interesting about the genomic testing, how now you can kind of look at a more general or broader, test, for a variety of different issues. And so thank you. This was incredible. And we are going to continue this conversation on with the next webinar on March 1st. So, we're going to talk a little bit more about research on that and liquid biopsies, which we touched on today. So the invitation you got for this webinar, on the bottom of it is the invitation for the second part of this series. So please, pay attention to that. We will be sending it out one more time. And so you can RSVP to that. So thank you all for this important information. It's really important information on genetics of cancer, screening, diagnosis, and treatment. The Cancer Institute has a very long history of treating and researching cancer. And on these webinars, we highlight the work our cancer teams do for our patients. We can't do this work without your support, everybody. So thank you for considering how you may help support us and help support these clinical trials that we're doing and the research that we're doing. Dr. Bilchik's doing some amazing work right now in colon cancer research and why young people are getting this disease, at earlier times in their life. So, we can't do this research without your help. So thank you for considering some support. Again, exploring genetic testing and the path to treatment will be on March 1. That will be with Dr. Gordon, Dr. Hoon, and Dr. Linehan. And so that's going to be a very good webinar as well. So until then, thank you for joining us today, and we look forward to seeing you soon. Take care, everybody.